was a great overview of COPD, and I have the easier job, which I think is to, first of all, thank you for coming on a beautiful evening, one of our few beautiful evenings we've had so far this year. And I'm going to talk about the treatment of COPD as it is today, and it's really just to set the scene for hopefully an interactive discussion about your questions about COPD. So, when I trained 30-something years ago, I think we were fairly, had a lot of trouble knowing what we'd tell patients about how to treat COPD. But things have changed. I think things are no longer hopeless. This is an overview of the Canadian guidelines for management of COPD. Now, down the bottom here, we've got breathlessness from when you first get the illness right through towards the end, which matches the problems with lung function that Dr. Sin has mentioned. So these are the components of management. First of all, you can see you need to be able to somehow avoid any further insults to the lung, no matter what the problem is. Exercise is critical, self-management and education, we'll come on to that. Then we use some medicines here, which I'll explain, bronchodilators. And then as you get more problems, we believe you need to really become enrolled in a formal pulmonary rehab program that I'll also describe. And then we have further medicines we use. We have finally a small percent of patients need oxygen, and even smaller percent of patients can benefit from special procedures. So I've got 3 slides just to say that a lot of what I'm saying is available, freely available on the web and in printed material and in handouts. So these are all Canadian sources that are beautifully done. Living Well with COPD. This is the website, Living Well with COPD, and the password, you can see the COPD. It's based from Saskatchewan, but it's got input from caregivers right across Canada. And finally, there's a world website for the GOLD, the Global Initiative for Chronic Obstructive Pulmonary Disease, or lung disease, and that's their website address, and there's a tremendous amount of material on that website as well about COPD for things you don't understand from tonight's presentation. So this is a personal action plan that anybody with COPD should have. These, again, from the Canadian guidelines, and it's a 5-point plan called PRIME, P-R-I-M-E. So the first thing is preventing further damage to your lungs once the diagnosis has been made. Second, relieve your symptoms. That means optimizing medicines and working on your attitude and coping mechanisms for your illness. Improve your general health and physical activity. Manage flare-ups or worsenings of your COPD with an action plan. And then finally, establish those around you that are going to help you manage this chronic problem, which, as Dr. Sin has said, is a really major problem in BC and right across Canada. So smoking cessation is critical. Now, smoking cessation, as many of you will know, is one of the hardest habits to give up, but it's not impossible. And actions that help include nicotine replacement, and this comes both in patches and put on your skin of various strengths, nicotine gum, it's a nicotine inhaler. In my view, if you wore a patch the rest of your life, you would come to less harm than from smoking. And in fact, you'd probably come to not much problem just by wearing a nicotine patch. So this can be a valuable adjunct on its own, or sometimes combined with medicines. And there's 2 medicines licensed for smoking cessation, Zyban or Wellbutrin and Champix. Now, both of these medicines have their problems, but they, as I can think of a university professor I saw recently, for her, Champix was a miracle drug. She managed to stop at 65. Actually, she's a psychologist, kind of thing, but managed to stop at 65 after years of trying, only because of this medicine that became available 2 or 3 years ago. Now, these medicines often work best along with counseling. Now, you can get counseling through the BC Lung Association, through the hospital clinics in BC, through online resources such as the Ottawa Heart Institute Smoking Cessation Program. They're useful. They're full of tips about how to begin the process of giving up the evil weed. One thing that I found useful, as was borne out in this study from the UK, was when we measure a breathing test in a patient, I can show them on a chart where their breathing is. And so if it's reduced, so here's a patient of mine who, at 52, who had the lung function of a 75-year-old. So he'd lost a lot of lung because of his smoking. This had a powerful impact on him in terms of saying, this is real, the smoking's damaging my lungs, this is evidence of it, and it's kind of an incentive, an added incentive if you ever need one, to stop smoking. So here are some suggestions to reduce or avoid exposure to factors that are aggravating your COPD. Obviously, you need to quit smoking and avoid secondhand smoke as well. Avoid strong odors, which can cause airway narrowing. Avoid smog. Luckily, there's not a lot of smog in Vancouver, but certainly up in the valley in the end of summer, there is a significant amount of ozone and other particulates in the air. Some folks recommend not walking along very busy highways or near highways because the exhaust from trucks and cars can aggravate your COPD. If you've got bad COPD, it's common to be really quite anxious. That's because you're always struggling for breath. And so there are strategies that can be taught to help you reduce that anxiety. Breathing techniques, relaxation techniques. In the winter, it's important to dress warmly and cover your nose and face with mouth with a scarf so you can humidify and warm the air before you breathe it in. Try and stay in a uniformly heated environment. Be well hydrated. Avoid sudden strenuous activities. And in the summertime, generally avoid getting overheated. Now, infections, shown on the top right panel here, is an important problem because infections cause one of the leading causes of worsenings of COPD. So what can you do? You can't really actually avoid all infections, but there are some simple things to do. One is to get the influenza vaccine every fall. Every 10 years you can get pneumovax, which is a vaccination against pneumococcal pneumonia. It doesn't stop all pneumonias by any means, but it does reduce at least one cause of bad pneumonias. I usually tell folks, if you've got COPD, don't go on a crowded bus in the winter where there's lots of folks coughing on you. If you're at risk, you shouldn't work in a daycare with lots of small children that are full of viruses and bacteria most of the time. With the wrong occupation to choose, you'd really be better to be a computer programmer. So those are some of the things you can do for infections. The alcohol hand wipes you see all around hospitals now, they can reduce transmission of infections to you. These are all things that are general statements to help you with COPD. I'll come back to this action plan question a bit later. So let's talk about specific medicines first because these medicines do help. So the first medicine I'm going to talk about are bronchodilators. Now, so these are medicines that help open up the narrow airways that Dr. Sin told you were part of COPD. So we've got various kinds, something called beta agonists and anticholinergics. We've got short-acting and long-acting. So short-acting means 3 to 6 hours, long-acting 12 to 24 hours. So generally I start with using my patients when they first get diagnosed with mild disease. I generally give them a quick-acting, short-acting beta agonists. And the common ones in Canada are salbutamol or Ventolin and Bricanil or terbutaline. So patients, if they've got very mild disease, can often just get by taking a couple of shots of one of these things when they first get up in the morning and before exercise and can manage quite well. Other patients are going to need a combination of anticholinergics act on a different way. They're both opening the airways up, but by quite different mechanisms. So here again, there's the beta agonists, which are really derived from adrenaline. So they have the side effect of, in some folks, of causing tremor or heart racing. Those are effects that tend to pass off with regular use. They can be present for the first week or two of use, but generally are well tolerated. The long-acting versions of those drugs, there's only 2 currently available, many more coming on the market shortly. The 2 ones that are commonly available are called salmeterol or Ceravent and formoterol, which is Foradil or Oxys. Now, these act for a longer period of time, and because we know that in COPD the airways are always narrowed, it makes sense to always have an agent that's keeping the airways open over the 24-hour period. So taking a beta agonist, the long-acting beta agonist, twice a day tends to do that. It has I should hasten to add that the evening dose of long-acting beta agonists often causes cramps, especially in older folks. So you need to be conscious of that. If you've got a lot of leg cramps, which are common in the elderly, sometimes they can be made worse by these medicines. So sometimes I just use them in the morning if cramps are a problem. Now, the anticholinergics, we've got the trade name of the only one we've got is Atrovent. Its real name is ipratropium. This is a medicine that you need to take 3 or 4 times a day. The way it's marketed in Canada, the dose it's marketed, if you want a maximum dose, it's actually 4 inhalations. And I typically give it through a chamber, which is designed to make sure it gets well down and deep in the lung. At the moment, we have one long-acting version of these drugs, which are called LAMAs, but they're long-acting muscarinic antagonists. There are more coming. So these are, again, maintenance treatment for COPD, been shown to reduce disability and worsenings, improve quality of life. There's only one, and this is it here, Spiriva. It's fairly expensive. It's around about $2 a day. If you are if you're retired, the government will pay for it unless you've got a high income, when you have to pay the first amount for the year. Occasionally, it can cause a dry mouth, and in men, occasionally, it can make prostatism a bit worse. These are in a minority of folks, but it's like all medicines and all diseases. Some medicines work better for some people than other medicines. So this is something we would typically try when the disease gets more than mild, and if somebody gets good benefit from it in terms of exercise tolerance, we would continue it. It has the advantage of acting for through the day and the night, which is a good, important thing in COPD. Now, until recently, we had a very useful medicine on the market called Combivent, which was a combination of Atrovent and Ventolin. It's actually not available right now, I don't believe. It was a good medicine. It was shown to help patients substantially. Another medicine that was widely used in the 50s, 60s, and 70s are tablets called theophylline. There's 2 common ones in Canada, Theodor and Unifil. Now, these medicines can help, but the problem is they can have side effects. They can cause heartburn and reflux. They can cause your heart to race, and they have become much less commonly used for those reasons. I still do occasionally use them when I'm really struggling with somebody who in terms of their mobility or frequent admissions to hospital. And often, in fact, I use a much lower dose than the recommended dose. So just a touch of theophylline can be helpful. Particularly, unfortunately, if you're still smoking, they may have a special role to play in that situation. Now, Dr. Sin mentioned that there's inflammation in the lung, in the airways and in the lung parenchyma in COPD. So anti-inflammatory medicines, which are used both for asthma and COPD, can be helpful. Again, not all patients benefit, but some do. So there's at least 6 or 7 anti-inflammatory medicines in the market in Canada, but by far the 2 most commonly used ones are Flovent and Pulmicort. Now, they have been shown in more severe disease to reduce worsenings of COPD, and they're usually, in fact, used based on research in combination with a long-acting airway opener. So here is Advair in its pressurized metered dose formulation, and as the discus. And here is the competitor, which is Symbicort, again, a combination of Pulmicort and Formoterol versus the combination of Flovent and Ceravent. So this comes in 2 formulations and that in 1. In the States, this is also available as a puffer as well. So these medicines can help. Dr. Sin's done research that clearly shows they can be helpful. Not helpful in everybody. They're expensive. And the other thing that I want to emphasize, and this is my own view, not shared by everybody, is that you need to be careful of the total dose you use. So I encourage my patients to look at the amount of medicine they're having. And so the total daily dose of Flovent or fluticasone, whether it's an Advair or there, should be 500 micrograms in my view. for most patients, and for Pulmicort it's 800 micrograms. Above that, I think there can be side effects that outweigh the benefits. So again, putting these two medicines together makes things simpler, and many of our patients are on so-called triple therapy these days, which is there's two medicines in each of these, and the third medicine would be a long-acting anticholinergic, Spiriva, and that's kind of state-of-the-art. But there's things beyond medicine. So, as you know, patients with these two patients have the same degree of airflow obstruction, but this person is obviously very thin. This person's of normal weight. So some patients have a constant loss of weight, and this is a very bad thing in terms of their outlook. And so it's very important if you're losing a lot of weight to draw that to your physician's attention and your caregivers so that you can get special attention. There's various reasons why that's happening, but it can be a major problem. So what do we do about nutrition and COPD? Well, the usual motherhood statements, really. Eat healthy foods, get to a healthy weight, lots of fruit and vegetables, protein foods. If you get short of breath in your eat slowly, eat more frequently, eat smaller meals. If you're overweight and you've got COPD, it's a big stress on your lungs to carry a lot of extra weight. So weight reduction can help you. Of course, some folks are underweight. So if you're thin, supplements such as Boost or Ensure can help. This is not evidence-based. There's, as you know, the whole question of supplements in medical problems is a very complex issue. So until further evidence comes out, I don't see anything wrong with taking a multivitamin a day, particularly if you're having trouble getting a good intake in. There's some evidence that vitamin D is helpful for Canadians in the winter at least, for lung disease and other problems, so 1,000 units a day of that. There's some evidence, again, that fish oils, omega-3 fatty acids, can be helpful, and it doesn't seem to be any harm, and they seem to be helpful for other things. Antioxidants in general, like things like broccoli, green tea, are full of antioxidants. The lung is exposed to an oxidant burden, diesel particles and other things that we breathe in, off gases from stoves in your home if you're using natural gas. All these things are a stress on your lung, and if you've got COPD already, it makes sense that the more antioxidants you have on board to counteract the oxidating things you're inhaling that can damage your lung makes sense. Although, again, a lot more research needs to be done to prove which of these things is the right thing to do. Now, rehab, pulmonary rehabilitation. Within the Lower Mainland, I think there's probably 6 or 7 different pulmonary rehab programs now, and these have been shown to make a difference when your COPD is a problem. So what are they? Well, the key thing is to think exercise is medicine. So frequency, you can write a prescription, 3 to 5 times a week, moderate shortness of breath, 30 to 45 minutes, and a whole variety of activities are helpful. The benefits have been shown that they can actually reduce your sensation of breathlessness, improve your ability to walk, improve quality of life, reduce leg discomfort, decrease the sense of fatigue, you actually will cost the system less money, and maybe you'll even reduce the risk of dying. So these are all obviously things we all desire to have. I should mention that, there's no point in taking Advair and Spiriva, $4 or $5 a day of medicines, if you're not doing these things, because you can open your airways up with these medicines, but if you don't exercise more with that improved lung function, it's really not an ideal thing. So a rehab program is more than exercise. That's part of it. It also involves a lot of discussion about how to use your medicines, and that's very important. We know that 50% of patients cannot use their medicines correctly. We like inhaled medicines, lung doctors, because we're delivering the medicine straight to the site of the problem and avoid some of the side effects of giving medicines that go to every cell in the body. But you need to know how to use those medicines. You need to know what to do when your COPD gets worse. That's part of the education. You can learn about relaxation techniques in these classes, behavior and lifestyle modification techniques, and get some support, which is often sorely lacking if you have COPD. So these programs typically are run by a variety of health professionals, respiratory therapists, physiotherapists, and physicians, and dietitians, and exercise specialists. And together, they have crafted these programs, and they've been going through a continuous process of modification and upgrading to allow them to be optimal. So here's part of them. You can do it on a stationary bike or on a treadmill, and aiming at an intensity of 60 to 90% of your predicted heart rate, or 50 to 80% of your maximum oxygen uptake. 20 to 45 minutes, 3 or 4 times a week, even twice a week, though, has been shown to be beneficial. You can do other things, stretching daily, static exercises, balance exercises, resistance activities are helpful, doing as well as exercise as well. Now, what about action plans? So here is a COPD action plan that lists your physicians, talks about your usual symptoms and your usual medicines, and tells you what to do when your COPD gets worse. So here is some of the medicines you can use if your COPD gets worse. There's 2 main groups. One is oral anti-inflammatories, corticosteroids. The other thing is antibiotics. Now, prednisone, of course, as you know, a lot of people are anxious about using prednisone, but here we're talking about short-term use, 35 to 50 milligrams a day, 7 to 10 days, which usually gives you most of the benefits without many side effects. And the antibiotics, studies have shown that for most folks with COPD, you can use simple old-fashioned antibiotics, amoxicillin, cefuroxime, tetracyclines, cotrimoxazole, not the expensive, fancy things. They do have a role, the expensive, fancy things, but only if your sputum shows certain bacterial properties. So most of my patients have some prednisone at home and an antibiotic. They filled the prescription. It's on the shelf in their cupboard. So if their family doctor's away, they can activate their action plan as necessary. So here's some of the things on that action plan. So basically, if your sputum becomes more yellow or more green, there's more of it, you should take an antibiotic. If you become more short of breath at the same time, take the prednisone as well, and increase the use of your reliever bronchodilators, your Ventolin and your Atrovent, etc. So these kind of plans can be worked out with your healthcare provider, and have actually been shown to reduce your chance of having to go to hospital, which is a good thing, gives you a sense of empowerment, and can help keep you well. What about oxygen? Now, people get very confused about oxygen. The thing that you need to be aware of is that getting short of breath doesn't mean your oxygen level's low. Getting short of breath is because the pump, the lung pump, the thoracic pump is struggling because the airways are collapsing. It's hard to breathe in and out. The resistance to breathing is increased. So most patients, in fact, don't need oxygen. We have very strict criteria. The government will pay for oxygen only under certain conditions, and that is your oxygen level has to be below a magic number, which is around about 88% with an oximeter, or 55 millimeters of mercury if you actually do a direct measurement of oxygen in your blood. So under those circumstances, it's been shown to prolong life, but the majority of patients don't need it. But we do sometimes test oxygenation during sleep, and if it's below 88% for a third of the night, the government will pay for oxygen, so you sleep with oxygen on, and that will improve your daytime functioning. Studies have shown that exercising with oxygen, if your oxygen's low, can be a little bit helpful. It's not really clear whether it's the right thing to do for most patients, but occasionally it can be useful. So, in conclusion, in this overview, despite having COPD, you can lead a healthy and fulfilling lifestyle if you comply with your medications, watch your diet, watch your exercise, and your sleep. And that's the message. Even with existing we've got a long way to go to improve the prevention of COPD and improving capacity. But we have made a lot of progress in certainly the 30 years that I've been practicing. And I know that Dr. Sin and I are very happy to answer any questions at this point. No question is silly. You should realize that. We quite welcome an open discussion, although I have to answer my page because I'm on call.